These are classic signs of PAD. Very easy to diagnose, but nonetheless, repeatedly we see how for years and months together patients appear to be underdiagnosed and mismanaged. And I don't think it is done in a willful, malicious way. It just happens that since we are down a half an hour of this discussion, we'll take a brief break and we'll come back quickly to continue the second half of this discussion. And keep tuned in, and we'll come right back in a few seconds.
I never thought it would happen to me.
I never thought it would happen to me. I didn't know women my age were at risk for heart disease.
Heart attacks are by far the most common cause of death in the United States of America. Many occur with no warning symptoms at all. Cardiovascular Institute of the South is the leader in treating cardiovascular and peripheral vascular disease. If you think you may be at risk of having a heart attack, come see us at any one of our 11 locations. Even the very best heart care is of value only if you have access to it. So here's our pledge. If you have chest pains or symptoms of a heart attack, you'll be seen at any hour, day or night. If you don't have symptoms, but you or your doctor have concerns about your heart, you'll be seen within 48 hours. And even a routine heart check will normally be scheduled within a week. CIS is one of the largest, most advanced facilities in the South with an international reputation for treating heart disease. Call us to schedule your appointment.
Good evening and welcome back to our live call-in show from the heart. This is from Opelousas General and Cardiovascular Institute of South, but we have special guests tonight. Both Dr. Kavros and Dr. Patterson have taken valuable time off from their families to come and sit here in this discussion to talk about the topic of the night, as well as to answer any questions pertaining to cardiovascular problems related to any of the patients that are seeing it. Both Dr. Patterson and Dr. Kavros have in excess of a decade, so way in excess of a decade's experience in advanced interventional cardiology, including structural heart disease, as well as experience in peripheral arterial disease. And of course, we are all general cardiologists to begin with. Both of them have joined us and enriched our practice. Here they started practicing at Lafayette General Hospital, and they are in charge of the cardiovascular program in Lafayette General Hospital. So they'll be very active taking care of patients there, as well as with the newfound partnership between Opelousas General as well as Lafayette General, we will be having a lot of interaction and sharing of the wealth of the information we have between both these hospitals. So I want to highlight that partnership between Lafayette General and Opelousas General Hospitals in the recent past, which we hope will go from strength to strength here too. And with that, we were talking about peripheral arterial kind of leg pain. Is it just arthritis, or is it just old age, or is it more than that? And we're trying to focus a little bit on peripheral arterial disease problem, or the PAD that you more commonly see on TV. Years before, it wasn't there. Now I think it's getting in the public jargon that PAD. Oh yeah, I have PAD. Now finally they're like MI, like stroke. They understand the seriousness of peripheral arterial disease, like we talked about how the coexistence of peripheral arterial disease and coronary artery disease, why it is so important to diagnose. It's not just PAD anymore. And having PAD means a significant risk. That, Nick, we'll go back to the continuation of this discussion we had. We talked about CT angiography being one of the diagnostic tools. How, in your experience in the past 5 to 7 years, we have seen very advanced office-based imaging that is very sophisticated. What do you think of CTA?
CTA is just an amazing tool. I mean, I've been very, very blessed to see a progression or evolution of different technologies. And when we started out, we had very rudimentary capabilities of imaging. But now, thankfully, we have very, very good advanced technologies. CT angiography, or a CAT scan, basically with dye injection, basically is a test that gives us very, very detailed information about the anatomy of the arteries. And it can show us really percentage blockages. It can tell us what's in that buildup of a plaque inside the arteries. Is it calcium? Is it hard? Is it, is there an aneurysm there? It can tell us the extent from basically, from your belly button all the way down to your toes. and very, very detailed pictures. And it has been a very, very, very useful and a go-to tool in our practice for looking at patients who either have, disease that's not too well defined in the other non-invasive studies, or in a patient who we're looking at intervening on. In other words, doing something to alleviate their discomfort or the blockage. And we're looking to understand a little bit more about the anatomy so that we can plan their procedures accordingly. And it's been just an invaluable tool, to do. And the images are just fantastic, and they're getting better every day.
Absolutely, and we can dedicate a whole evening or many evenings talking about CT angiography. And definitely, as you said, I mean, while it has come on with a great deal of promise in the coronary or heart arena, it seems like it has become more fruitful at this stage anyway in the peripheral arterial disease arena. And John, we all have enjoyed being in this vascular type of thing, having that ability to see it, not be surprised when you take them to the lab.
Right.
You're assuming that the patient have a certain kind of problem, and you're trying to put catheters or inject dye or fix the problem. You go in there, lo and behold, you have a whole host of different blockages, or you have blockages on the same side you're going in from, which defeats the whole purpose of so it has really made the planning of endovascular procedures substantially better.
Sure.
And of course, it also highlights the whole anatomy like you won't believe it. So it just really sheds a great deal of light. Talk about CTA in the coronary arena. What do you feel, where do you feel it stands now?
Well, we're still struggling with just the right patients to use this, and the limitations for the coronary CT is that you get good image from the very takeoff of the artery to about midway. But once you start getting towards the ends of the arteries, you really don't get the same detail that you need to make a diagnosis. You can estimate that there's plaque there, there's blockage, but it becomes much harder. If there's lots of calcification, there can be shadows created that make reading the image much more difficult, certainly indicating there's plaque there, but we're still challenged with this, how specific can that image be for us. In patients that you have multiple risk factors, some suspicion, maybe they're not the best candidate to undergo cardiac catheterization for one reason or another. In that setting, it's a great tool. It's fantastic because in those patients, one of the questions is, do they have significant plaque burden or don't they? And the CT angio can definitely give you an idea how much plaque. Is there everywhere? Is there just sort of a little bit of plaque? Is there lots of calcium? I mean, it's great for that. And calcium we relate to more advanced disease and more severe disease. So if we see lots of calcium, then we're more pressed to go ahead and do the coronary angiogram and then potentially be prepared to fix a blockage. So it does have a role, but it's still limited. It doesn't give us the same anatomy and detail that you can get for the periphery. The peripheral arteries are larger. If you imagine, the iliac artery, the leg arteries, they're bigger arteries than what we have in the coronary by a magnitude. And so
they're kind of fixed and they're not moving, they're just sitting there.
That's right.
So your imaging is...
Yeah, that's exactly right. One of the questions that I have for you with the body CT angiogram, do you find that it results in less contrast and perhaps less risk to the patient because you're better planned and you're not using as much dye to sort of find your way?
I think that's right. I mean, with the CTA having all that information lined up, and you have this one peripheral line, of course there is a risk of contrast and a little bit of radiation associated with CT, but it definitely takes away the risk each time we put in an invasive a needle in an artery, put a catheter in an artery, you take them to a hospital, and there is a finite risk in this day and age, but nonetheless it is not totally negligible risk.
No, and we've been in the business a while, and we know that statistics say 1 in 100 patients have a complication, not necessarily because it's just because of the nature of the disease. Right. Either having a heart attack or stroke or needing urgent open heart surgery. So, and we've done thousands of these, and
it happens very, very quickly before in a bad of a lid. I mean, you can have issues. So.
Sorry, go ahead.
Well, I was going to say, I have a good example even from my clinic today. I have a lady that she definitely needs a coronary angiogram. The question was whether she had severe blockage in the artery to her kidney. And this is not a light procedure for her. She has problems with the kidneys, and she has potentially some issues with the valve, et cetera. So in order to instrument her less and not put catheters directly into the kidney artery, I thought, well, we'll get the CT angiogram. And lo and behold, she doesn't need to have catheters placed in the artery to her kidneys. So for
it
me,
definitely has changed the whole way now. It really, and of course, coming to carotids, as we all know, that putting catheters in the carotid arteries and injecting gives a great deal of information. Certainly, each time you put a catheter, as all of us know, that the brain is extremely unforgiving when we put in there and you inject even the tiniest piece of an atheromatous material or a tiny piece of clot just related to catheter manipulation can cause an unforgiving stroke, as all of us know. So doing that CTA for the carotids has become a big deal. It has replaced traditional angiography almost.
Another issue with the CAT scan, the CTA, or just even the calcium scoring, it is a very important tool for risk stratification. So in order to tell a patient's risk of having a heart attack or stroke or a major vascular event down the road, it is a useful tool to get that simple calcium score. And if it's very low, that kind of, imparts a very low risk of adverse, cardiovascular events down the road. Additionally, we also have these patients who, they may have one risk factor, but they're overall pretty healthy. They've been having these chest pain syndromes, and they've had a negative stress test, but they persist in having chest discomfort. They've gone to their gastroenterologist. They've had the endoscopy. Nothing's been found there. So, you don't really, in your heart, I can't put catheters in this patient. So the CT angiogram is very helpful in those cases as well, because the negative predictive value, in other words, the ability to exclude coronary disease is very, very good with this test. If it shows you no plaque or very little plaque, you're good, you're fine, you move on. But if it shows something, then you really have to look further.
Right. Absolutely. And I want to remind our audience again, this is a live call-in show, and we're discussing about leg pains and peripheral arterial disease. Is it arthritis? Is it old age? Or is it something else? But I do encourage our patients to call in with questions regarding leg pains, regarding PAD, or other vascular problems. Here we talked about some of the presentations of peripheral arterial disease, some of the patients that are susceptible to peripheral arterial disease. We just and how do you diagnose them, and we want to kind of move on into the, how do you treat them? No, okay, we know a patient has peripheral arterial disease, and of course we all know that there are many ways to skin a cat here, but what is your general algorithm to treatment of patients diagnosed with PAD at different levels? How do you approach them?
If a patient comes in with discomfort in their leg that's due to artery blockage, you first try medical therapy with a walking program. Medical therapy being addressing all those risk factors that got that patient there in the first place, making sure their cholesterol is rock bottom low, make sure their diabetes is very well controlled, make sure their high blood pressure is very well controlled, and tell that person to go on a walking program. And the way they do it is they're supposed to walk for about 30 to 45 minutes, 5 times a week. They walk at a moderate to fast pace. They walk till they get that discomfort in their legs, stop, stand still, get relief, start up again. And they do that cycle for the entire 45 minutes. Usually, in the majority of patients, I can tell you, within about 3 to 4 weeks, they should feel some improvement in their symptoms, being that they can walk farther and longer before they get that discomfort. And if everything else is okay, that may be all we need to do. If that pain is tolerable to the patient and not inhibiting their lifestyle, not inhibiting from doing the things that they need to do on a daily basis, whether it be a waitress that needs to get from table to table or somebody, walking on an oil rig, if they're fine with that, small level of discomfort, then we've done our job. We've halted the progression of disease and improved their symptoms. If, however, they are not comfortable with that approach and they do not do well on that conservative therapy, there are other options that we can consider, either opening up their arteries with the different minimally invasive methods that we have, using catheterization procedures with lasers, balloons, stents, other atherectomy devices, or shaving off plaque, and alleviating their discomfort. And in some instances, we also need surgery as well to help.
Absolutely. And of course, as you said, like for minor single level blockages, certainly encouraging them to exercise, and definitely quitting smoking and all these other aspects would do. But of course, if they have multi-segment problems, or if they have this critical limb ischemia, or if they have below knee disease in the small arteries, those would definitely call for some of these interventional, which are probably beyond the scope of this discussion, to talk about all the specific interventional options, which may be a bit esoteric and advanced for the general audience. We'll try to stay out of it, and we'll try to maybe touch on the varieties of it.
Yeah. The good thing is, just to kind of impart to our audience,